Hi there, my name is Brad. Welcome to Omnibody Healthcare. In this episode, and this is actually the first episode of a brand new series that I've just started doing, in which I'm going to take a piece of research, a full article on a different topic, obviously every time, and I'm going to break it down to you and talk through all the findings that I find most interesting for me and hopefully for you as well, okay? So in this episode, we're going to talk about deep gluteal space problems, which will include Piriformis syndrome, ischiofemoral impingement, and sciatic nerve release, okay, amongst some of the things that we're going to cover, right? So what I've done here, I'm going to use this article which I found on the National Library of Medicine. Before we start, obviously I need to acknowledge the people who created the article and the research itself. So Luis Perez Caro, Moises Fernandez Hernando, Luis Cerezal. I'm sorry if I'm pronouncing this wrong. My Spanish isn't great. Ivan Saenz Navarro, Ana Alfonso Fernandez, and Alexander Ortiz Castillo. Okay, so these guys and obviously others have done a great job in talking about something that's quite underdiagnosed as a condition. So we're talking about DGS, or deep gluteal syndrome. Most of you have probably heard of it because this research came out in 2016, even though a lot of people could have missed it. And the aim of it is to prove to you and give you evidence on deep gluteal syndrome as a condition and the difference that it has to Piriformis syndrome, and essentially class Piriformis syndrome as a type of a subtype or a subgroup to the deep gluteal syndrome as a whole, okay? Because a lot of the injuries, as you're going to learn from here as well, a lot of the injuries that occur in the deep gluteal space as a region in the body will essentially be connected to Piriformis syndrome, because that is one of the conditions that's been researched heavily throughout the years, and you're going to find a lot of material online. There's so much stuff there, okay? Whereas some of the other conditions that we're going to talk about here haven't really been researched as much, and there's not really as much information, and you're going to find out why, okay? So there's a specific reason why that is. On the right hand side of my screen here, you can see the notes that I've took. So I essentially spent a couple of hours going through the research paper, and I kind of highlighted things that I find interesting for myself and I thought that I'm going to discuss. At the same time, I pulled out these notes on the right hand side, and obviously you're going to find these notes underneath the video. So without further ado, let's go into the research paper. So the deep gluteal syndrome is an underdiagnosed entity characterized by pain and or dysesthesias in the buttock area, hip or posterior thigh, and or radicular pain due to a non-discogenic sciatic nerve entrapment in the subgluteal space. What does this mean? In short, we're talking about a condition which is occurring not due to a disc-related injury. So we're not talking about a bulge or a herniation here or any other type of injuries that occur around the nerve roots and around the disc. So essentially all the conditions that we're going to cover in this in this paper are going to be conditions that are creating injuries in the deep gluteal space due to compression, either muscular or fibrous. This will be another thing that we're going to look at. The different muscles that can create the compression, essentially anatomical relations between the sciatic nerve and the muscle tissue that you can find in this area, which will be quite interesting because some of you have probably heard the different kind of positions of the sciatic nerve that it can kind of have in the around the piriformis. Really, that's the best word. You're gonna see that what I mean in a second. So essentially, as this little highlighted text says here, we're gonna look at Piriformis syndrome, which essentially has nothing to do with some of these other conditions. So again, I've got them here in my notes. So we've got fibrous bands, which will be one of the conditions that we look at. If you haven't heard of that, then you're gonna learn about it later on in the video. Piriformis syndrome, obviously, we're going to talk about obturator internus and gemellus complex syndrome. So these will be the muscles known as obturator internus, gemellus inferior, and gemellus superior. These are the muscles that we're going to look at and essentially how they connect to injuries that occur in this area. Quadratus femoris, or the ischiofemoral pathology, We're going to talk about that as well. And lastly, we're going to finish with hamstring conditions. My aim with dissecting this research paper is to help you understand the differences between all these conditions and help you understand where like each one is like sits, in terms of in relation to the other ones. So DGS or deep gluteal syndrome is a under-recognized and multifactorial pathology. That's obvious because there's so many different injuries that I've just mentioned a couple of seconds ago that essentially are going to have similar symptoms. By the end of the video, you're gonna see how I've classed everything. But all these things that I've just mentioned here a couple of seconds ago, that you can see on the right hand side, these are going to be the subtypes or subgroups of deep gluteal space syndrome, because they can occur separately from that, and they can have different symptoms. There's going to be a different cause for all of these injuries, okay? Which is the most important things. How do we determine the different causes? And so for some of these injuries, it will be very difficult for you to determine exactly whether it's them causing it, because let's keep in mind that what these people have done here, they've actually dissected cadavers, and a lot of you are probably not gonna do this, but it's just interesting to know, like, with dissection, what people uncover, okay? In the first chapter of this research breakdown, we're going to talk about the muscles included in the deep gluteal space. Because if we say deep gluteal space, what are the muscles that you come up with yourself, right? So pause the video, take a pen and a piece of paper, and just write down all the muscles that you think would be a part of this region, okay? Now, obviously, you can do that optionally, so it's not necessary to do it. But if you've done it, let's try and have a look at some of the muscles that we're going to talk about mainly in this area, okay? Now, the muscles that I've got highlighted for me will be the piriformis, obviously. We've got the superior gemellus muscle, the obturator internus, inferior gemellus, and quadratus femoris. These will be the main muscles in the deep gluteal space that we're going to look at. This doesn't mean that there aren't others. Okay, so there are other muscles obviously that you have in the area, but these are the main ones that relate to the injuries that I mentioned a couple of minutes ago. Okay, obviously we're going to cover the actions of each of these muscles, and you're going to see what these abbreviations here mean. So for those of you listening on the podcast, I've got a couple of kind of abbreviations, next to each of these muscles that essentially will make it a bit easier for you to remember what their functions are. In the research paper, you have a bit of a description of what the deep gluteal space is. And if I haven't mentioned this already, I'm going to have a link to the research paper for you, either under the YouTube video or in the podcast information, or under the video if you're a member of the Bulletproof series, so you can just read it yourself, okay? So the subgluteal space is the cellular and fatty tissue located between the middle and deep gluteal aponeurosis layers. Okay, so beneath the gluteus maximus. This is what's interesting here. So essentially, if we switch the screen now to my anatomy model, as you can see what I've done there, I've actually removed the gluteus maximus. So let's hide on this side as well. And there we go, we've got the deep gluteal space. Now, what we need to do though, we need to be a bit more specific as to the area. So within the space superior to inferior, which means from top to bottom, we're looking at the piriformis, superior gemellus, obturator internus, inferior gemellus, and quadratus femoris. These are the muscles that are included, okay? So if you included these, if you were one of the people who paused the video a couple of minutes ago and you wrote these muscles, then good job to you, okay? Now let's have a look at an image that I kind of opened up so we can have a better visual perspective on the actual deep gluteal space. Okay, here it is. This is an image that I found on Google. So basically you've got this circle is essentially the deep gluteal space. The gluteus minimus is not really a part of what we're talking about here, but we've got the piriformis, which is on the top here, right? So the biggest one of all of them, and you're going to understand why it's the biggest one, and the most complex. You got sciatic nerve underneath it, which will be something that we're going to talk about in a second as well. The position of the sciatic nerve in relation to the piriformis, that's very interesting. You've got the gemellus superior, which is this one here. You've got the obturator internus in the middle, and you've got the gemellus inferior. And obviously at the bottom here, you've got the quadratus femoris. okay, which is a muscle that is going to relate to a separate condition, okay, that we're going to talk about later. So this is the deep gluteal space, and this is the sacrotuberous ligaments here as well, connecting on the ischium. So down here we've got some information on the different muscles. So first of all, talking about the piriformis muscle, this muscle arises from the ventrolateral surface of the S2-S4 sacral vertebra, gluteal surface of the ilium, and sacroiliac joint capsule. It runs laterally through the greater sciatic foramen, becomes tendinous, and inserts to the piriformis fossa at the medial aspect of the greater trochanter of the femur. Okay, so often partially blended with the common tendon of the obturator and gemelli complex, which is very interesting. So the tendons of these muscles, these four muscles, because the gemelli complex means both of the superior and inferior gemellus muscles. So all these four muscles can have a blended kind of tendon. All these injuries, when they occur, the symptoms that you can feel as a patient and the results that you can get from testing as a practitioner, a therapist, or PT or whatever, can resemble each other. Okay, so this is what's interesting. How are we going to differentiate between all these injuries, right? So that's things that we're going to talk about. So we've got obviously the branches of the L5S1 and S2 spinal nerves innervate the piriformis muscle. This is interesting here. This is actually one of the key points that we need to look at. There are 6 possible anatomical relationships between the sciatic nerve and the piriformis muscle, which means there are 6 different positions that the piriformis and the sciatic nerve can essentially have between one another. Okay, so obviously the most common position is going to be position A here, which we've got, which is essentially the sciatic nerve passing below the piriformis muscle. So it's this black text, black highlighted text with white letters here, and it's essentially this first image. So essentially, this as well. So you got the piriformis, you got sciatic nerve, superior gemellus, obturator internus, inferior gemellus. They've missed the quadratus lumborum here, but you don't femoris, not lumborum, that's up here. You don't really need it. And the sacrotuberous ligament. So this is the most common position of a relationship between the piriformis and the sciatic nerve, where the sciatic nerve essentially passes underneath the piriformis. And you're probably asking yourself, how do they know which relationship is most common? Again, they have dissected cadavers. So I'm going to mention this in a second, but you can see here that there's been, in one study particularly, there's been 120 cadavers, and in another one there was 130 cadavers. That's a lot of cadavers. A lot of these dissections, there's patterns that are discovered, and that's how research kind of gives us evidence, right? So position A, like we said, the piriformis muscle passes underneath. Position B, you've got the divided nerve, which is the sciatic nerve being divided, passes through and below the muscle. So essentially, you can see it here, position B. This is a part of the sciatic nerve which pierces the piriformis, and another part, the bigger part of it, goes underneath it. So essentially, you can see these fibers here of the sciatic nerve on part A. Instead of these fibers coming together, one of them detaches and passes through the piriformis. Now, a lot of you are probably going to ask, like, why is this happening? And I have no idea. These guys have no idea as well. It's just some sort of a anomaly, if you can call it that way, or it's just the way it is. Okay, so there's no explanation why that happens. But based on the research, what you're going to find here, and I've got that in my notes here as well. The most common sciatic nerve and piriformis relation in 120 cadavers dissected. This is a research paper from Beeson and Anson. Number 1, 84% will be undivided nerve passing below the piriformis muscle. And number 2, 12%, divisions of the sciatic nerve essentially through and below the muscle. So point A and point B, or relationship A and relationship B, are the most common in both studies here, because I've got another one which was also referenced in this one. So Piscina, or I'm not sure how you kind of say that name, but in 130 cadavers, same results. 78% undivided nerve passed below the muscle, 21% divided nerve passed through and below the muscle. Okay, so this seems to be a pattern. So we've got 250 cadavers giving us very, very similar results here, essentially. And obviously in very small circumstances, you've got some of these other, there's 4 more relationships that we're going to cover as well. So relationship 3, or C, a divided nerve passes above and below the muscle. So essentially, again, the sciatic nerve splits, but this time, instead of piercing the piriformis, it actually goes above it as a fiber. So essentially the same division as this, but the main part of it, the bulk of it, passes underneath the piriformis. Okay, and obviously you can it makes sense now based on the pictures. You got D, which is relationship number 4. The full sciatic nerve pierces the piriformis, which is a very rare condition and very, very unpleasant. You know, imagine that kind of nerve essentially living its life in between the fibers of the piriformis muscle. Okay, relation number 5, E, you've got above and through, basically. So here we had through and below, and now we've got above and through. Okay, so essentially E is similar to B, and again, you got a couple of fibers that go between the fibers of the piriformis, and some of the fibers of the sciatic nerve go above the piriformis. And then finally, we've got, probably for me, the most interesting one, 2 piriformis muscles. And between those 2 piriformis muscles, you've got the full sciatic nerve, all of its fibers going in between them. So essentially, this is a combination between this is very rare, and a brand new kind of condition where what this AP kind of means here is like an accessory piriformis muscle with its own tendon. So this piriformis has its own tendon, which makes it a separate muscle or an accessory to the main piriformis, which is crazy. Okay, so imagine having 2 piriformises, right? So these are the 6 relations that you can have when it comes to, the piriformis position. So piriformis syndrome as a condition, we're going to look at it later on as well, is going to relate to these 6 different positions, relations between the nerve and the muscle, because obviously, you can have symptoms of piriformis syndrome because you've got a portion of the sciatic nerve passing through the fibers of the piriformis, and the fibers of the piriformis are essentially inflamed or tight or overused, and that could increase your chances of getting piriformis syndrome. Hopefully nothing like this happens, that happens to you. There's not really much you can do about it. But for example, in position or relation number 4, where the sciatic nerve goes through the piriformis, that's even worse. So this is all going to relate to piriformis syndrome. And I've also got all of these relations here in my notes. So when you're finished listening to the kind of whatever if you're watching a video or listening to the podcast, you can essentially look at all these 6 different positions here. So A, B, C, D, E, and F. Okay, and obviously a couple of notes from the research papers that I mentioned. And now we're getting to the function, so the anatomical function of all these muscles. So let's talk about the piriformis, because it's the most complex in terms of function. So the piriformis muscle potentially plays a role not only in external rotation of the hip, but also in restricting posterior translation of the femoral head when the joint is flexed due to the shift towards a more posterior position of this muscle with respect to the hip joints in hip flexion. Hip flexion, adduction, and internal rotation stretch the piriformis muscle and cause narrowing of the space between the inferior border of the piriformis, superior gemellus, and sacrotuberous ligament. These are all kind of things that are interesting and are going to make more sense later on. What's interesting here as well, after leaving the piriformis muscle, the sciatic nerve runs posteriorly to the obturator and gemelli complex and quadratus femoris muscle. It passes between the ischiotuberosity and the greater trochanter, lying close to the posterior capsule of the hip. This is interesting because, as you can see, the sciatic nerve will move on towards the obturator and the gemelli complex. Essentially, injuries that can occur to the piriformis itself can have connections to all the other 4 muscles, and obviously we're going to talk about neurological connections later on, and what nerve innervates what. That's also interesting. Under normal conditions, the sciatic nerve is able to stretch and glide in order to accommodate moderate strain or compression associated with joint movement, which is obvious, right? So even though you've got these kind of positions of the nerve, so let's just say that, if the nerve passes through, the piriformis, you're not really necessarily going to feel pain only because you've got this condition, or a relation. It's not even a condition, it's just the way your anatomy is. This doesn't mean that you're going to have pain under normal conditions, which means that if the piriformis is, kind of not inflamed, or it's optimally contracting and obviously lengthening, if all these other 3 muscles and 4th one down here, if they're working optimally, if the joint isn't restricted, then this is not going to cause you a problem. This becomes a problem, obviously, when you've got the inflammation or problems with the udder or the fibrous bands we're going to talk about in a couple of minutes as well, or any of the other conditions that we mentioned earlier in the video. Now, before we move into the neurological connections here, and obviously I'm going to talk about the nerves that essentially innervate each of these muscles and what which muscles these nerves innervate and what sensory function they've got. I want to talk about the actions of the muscles, which is also interesting. So the piriformis muscle is the most complex out of these 5. And the actions that we've got here are external rotation, abduction, and extension of the hip joint, and also stabilization of the hip joint. And just like I mentioned a couple of seconds ago, during hip flexion, you've got restricting posterior translation of the femoral head when the joint is flexed. As well as, this is something that's not mentioned in this study, what I've also read in different studies is that during hip flexion, the piriformis muscle becomes a medial rotator. So if you can imagine, like when you flex your hip and you push your foot out and the knee in, that's medial rotation, and that's actually created by the piriformis muscle. Okay, so it's a very, very complex muscle, if you ask me. But for now, we're just sticking to its main functions, because I also had a look at some other studies here, which I'm also going to link underneath this video. I was looking at this. So piriformis electromyography activity during prone and sideline hip joint movement, and what this was kind of talking about, and I'm probably going to cover it in a separate video because it's its own research paper, you know, but this was talking about like which position of the hip essentially will give us the most activity with the piriformis, so the most activation. Okay, so but I'm not going to talk about it now because it's just going to send us down a different rabbit hole, so we'll kind of do a separate video on that. Moving on to the other muscles, superior gemellus, you've got the external rotation of the thigh, abduction, and extension of the hip joint. So let's kind of move the screen onto these muscles here, or actually you can even see them on my model, like the anatomy model here. So we talked about the piriformis first of all. Now we're talking about the superior gemellus muscle here, so on the top. Okay, so like I said, external rotation of the thigh, abduction, and extension of the hip joint. So I've got some abbreviations here, which essentially states ERAB, so ERAB, which stands for external rotation, abduction, basically, and I should probably put extension as well. That's probably something that I should have done earlier, but I've just noticed that I missed the E, so it kind of becomes, and we've got that here, that's fine. So you got extension at the bottom. So external rotation, abduction, and extension of the hip joint, superior gemellus. Obturator internus, exactly the same. External rotation, abduction, and extension of the hip joint. Inferior gemellus, you guessed it, exactly the same. So we've got Irabi on all these 3 muscles, as well as the piriformis. However, the piriformis has a lot more going on there, and obviously it functions as a stabilizer. And just a quick note here, the piriformis muscle and the pectineus, which is a part of the adductors, are very strong hip stabilizers. So that's something that I just kind of popped into my mind. I just decided to share it with you. Obviously, the pectineus being an adductor and having nothing to do with the deep gluteal space. So that's another story. And finally, quadratus femoris. You're probably thinking like, why, you know, this should probably be the same, but it's not. It actually creates, well, first of all, external rotation, which is the same, but a deduction. So it adducts the hip joint and it doesn't create extension. So in a way, these muscles, well, these 4 are muscles that support each other. They are agonists, you know, they kind of help each other. Obviously, these 3, so the gemellus, the gemelli complex and the obturator internus, they are, you know, a secondary support system for the piriformis muscle, but they are strong muscles on their own as well. But the quadratus femoris is also a support muscle here, but at the same time, it's an antagonist. So it will create, you know, an antagonistic movement when these are creating the abduction. This muscle is going to stretch, and when this muscle is creating adduction, these muscles are going to essentially do the opposite because they are abductors. This is what's interesting here, is the dynamics so deep in the deep gluteal space, and how these muscles that are essentially so close to each other. If you look at them like this, you wouldn't think about that. But they do create different movements, which is very interesting for me specifically. Now, the fact that the quadratus femoris is different to the other muscles will make more sense later. And essentially, this is going to be related to an injury which will be separate from an injury that relates to these three, which will be separate from an injury that relates to this one. So we talked about piriformis syndrome. And these are musculoskeletal injuries that we're talking about here, relating to like the muscle tissue. So piriformis syndrome. Here we're gonna have the gemelli and obturator internus syndrome, and then here we're gonna have the ischiofemoral dysfunction that I mentioned in the beginning of the video. So we've got the ischiofemoral pathology here related to the quadratus femoris. But I'm gonna explain why that is later when we get to those pathologies. Okay, now let's continue with the neurological function of the nerves that we've got in the area, because that's also interesting. Knowing which nerves are essentially a part of the deep gluteal space and are most important is also something that, you know, I always keep in mind, because, you know, for people like me and some of you, essentially knowing the muscles is not enough, because that doesn't really give you as much information. But having knowledge of the sensory and motor function of the nerves is actually more important, because if you know, for example, like which nerve innervates which muscles, then if you have an injury relating to, you know, a certain muscle, and it's not being able to, you know, if you're not able to rehab it with kind of the normal muscular related exercises and techniques, then it's always good to look at the nerve tissue. That's something that I tend to look at first, to be honest, because it gives me a lot of, it saves me a lot of time. And the sensory function is important, because a lot of these nerves are going to have a sensory function rather than a motor one, whereas some of the most complex, the more complex nerves, like the sciatic nerve, for example, is going to have both a motor and a sensory function. So we've got the posterior femoral cutaneous nerve. So I say this as if it will make sense to any of you, like to those of you who've never really seen this nerve visually. So I always like to do a visual representation of what I talk about as well. But before I do that, we've got sensory function. Like I said, some of these nerves are going to have a sensory and motor function, or some of them are going to have one of each. Innervation of the gluteal region, perineum, and posterior thigh and popliteal fossa. So gluteal region, obviously the area here, the perineum at the bottom, the popliteal fossa, which is essentially behind the knee, right? And essentially we've got the posterior thigh, which is the hamstring area. So what we need to do, we need to find this muscle. So this, I'm going to go over here, copy this and pop it in the search. And straight away we've got the posterior femoral cutaneous nerve, and let's fade everything around it. You should be able to see it there. So essentially this is the posterior femoral cutaneous nerve going all the way down here with its little branches. So like we talked about, the perineum area here, the deep gluteal, like the gluteal area, posterior thigh, and popliteal fossa behind the knee. So this is the posterior cutaneous femoral nerve here. Okay, we've got superior gluteal nerve, which is very important and interesting. This is a nerve that innervates the gluteus medius, the minimus, and the tensor fasciae lata. So I want you to notice how the gluteus medius and minimus are actually innervated by a different nerve to the gluteus maximus, which will be the inferior gluteal nerve. So essentially, the superior gluteal nerve is very easy to find. It's basically a nerve that kind of, this one here is the inferior, and you can't see it, but it should be one of these that kind of goes in here. There we go. So if I fade everything around, you can see it. So the superior gluteal nerve, let's fade again, is this one here. So obviously you can see it coming out of the body of what's eventually to be the sciatic nerve. But all these little branches, this is your superior gluteal nerve, innervating the gluteus medius, the minimus underneath it, and the TFL on the side. These are the muscles that are innervated here. So this is why whenever I work with gluteus medius injuries, I always look at the TFL and the gluteus minimus, because as you can see, these three muscles are innervated by the same nerve, which means that there is something something could be going on with the nerve itself. So it's never just a gluteus medius injury or just a TFL injury or just a TFL tightness. It could be a whole combination between these three and making it a lot more complex than you would think. And then, like we said a couple of seconds ago, the nerve that innervates the gluteus maximus will be this one here. This is the inferior gluteal nerve. So don't worry about these ones descending down. We don't want to talk about them now, but fade everything around. And you can see essentially this nerve is kind of going through the fibers of the gluteus maximus, just like this one is going underneath the gluteus medius, and some of it kind of piercing it and stuff like that. So, and as you can see, the gluteus maximus has its own, neuro kind of innervation, because it's a big muscle. It requires a lot of function. And again, this makes more sense as well, because a lot of people can activate the gluteus medius and the TFL. The TFL tends to overwork. At the same time, people tend to struggle with gluteus maximus activation. And just because you've got an overactive TFL and a partially active gluteus medius doesn't mean that you're going to have an active gluteus maximus, because it has a different nerve signal. Okay, so this is what's interesting here. Like, just because an exercise is made for a muscle, like for example, you say this exercise is let's take the squat. This should engage your glutes. It doesn't mean it will. Okay, so you need to work on essentially improving your motor control and your proprioception over these muscles by focusing and understanding the movements. Understanding exercises is what will help you make an exercise a lot more specific, a lot more focused on what you're trying to achieve. So these are all things that people tend to forget about, and that's why I wanted to mention it. Okay, moving on to the smaller nerves here. So we got nerve to the obturator internus, which is gives you motor innervation of the superior gemellus and obturator internus. So the muscles that we just mentioned, the superior gemellus, obturator internus, and the inferior gemellus, they're going to have a nerve that essentially supplies them, which again, all of these are going to be a part of the lumbosacral plexus. So they are connected in a way, but it just shows you that, like, why these different muscles can have like different innervations, and what this means is that they can have different injuries relating to them on a neurological basis. Okay, so and then again down here we've got the nerve to the quadratus femoris muscle, which is again easy to find because it's kind of superficial. So this is it here, quadratus femoris nerve. So it's tiny, as you can see, and it kind of goes into the quadratus femoris, which is here. And what's interesting here is that the quadratus femoris nerve essentially will innervate both to the quadratus femoris and the inferior gemellus, which is not innervated by the nerve to the obturator internus. Okay, this is something interesting. Again, the pudendal nerve, which is a bit more popular than the other ones that I've just mentioned, so innervates the perineal muscles, which is again the muscles of the perineum, very important. And essentially, talking to women who've given birth, those muscles for you will be very weak after, and obviously because they've kind of been spread over a long period of time. So this is why it's very important for you to do work for them, especially after giving birth or even during. Sometimes there's specific exercises that are very good. The external urethral sphincter, those are again muscles of the perineum. The external anal sphincter, again very important muscles, and sensory innervation to the perineum and external genitalia. So if you're someone who actually has symptoms of loss of sensory function, if you, for example, don't feel anything underneath there in those areas, this means that you may have an issue with the pudendal nerve. Fade others. Okay, so you can see exactly where it goes. So that's the right one, that's the left one. So it literally covers all these, so the levator ani muscles, which are underneath, the sphincter muscles, so these are again very important muscles when we're talking about hernias as well, and like core stability and that kind of stuff, even disc injuries, so it's just very interesting where this nerve passes through and its innervation patterns. And again, like, why not, when we're talking about all these deep gluteal space issues, why can we not experience symptoms that relate to pudendal nerve kind of compression? Because again, it's very close to the sciatic nerve here. It comes out of the sacral plexus area, so anything is possible, right? And finally, the big boy, sciatic nerve, motor innervation of the semitendinosus, biceps femoris, semimembranosus, all the hamstrings, extensor portion of the adductor magnus, and leg and foot musculature. So essentially, the guys got a bit kind of sick of listing muscles, so they just decided to kind of go for leg and foot musculature, because the sciatic nerve essentially covers the entire posterior chain, goes all the way down to the back of the knee, splits into the tibial and peroneal or common fibular fibular nerve, whatever you want to call it, goes underneath, the bottom, towards the bottom of the foot and the top of the foot. Essentially, all the symptoms that you have with sciatica, like that kind of lightning type of pain, sharp pain all over the pathway of the nerve. So it could be in the buttock, it could be on top of the hamstrings, middle hamstring, back of the knee, calf, Achilles, top of the foot, drop foot injuries. I'm going to cover that in a separate lecture. All those injuries can essentially be created because of the sciatic nerve being damaged somewhere or compressed somewhere. Okay, so all these deep gluteal issues, so the deep gluteal space syndrome or the fibrous band problems we're going to talk about, or anything else that we're going to mention, can essentially create symptoms of sciatica. This is essentially one of the key points that I need to mention here. Symptoms can overlap, and that's something that you should expect.